Hi, good afternoon everyone. I am Kate Terroni. I'm Chief Inspector of Adult Social Care at the Care Quality Commission, and I'm delighted to have you join us today. So if you've done team events, live team events in your organisations, you'll know that they're quite a different experience. So whereas when you usually do a Teams call or a Zoom call, you have the benefit of seeing people's faces and interacting and people chipping in and commenting. Unlike with the Teams live call, where it's very much a broadcast function. So I'm going to be talking to you, but I would really value, I've got my chat box open on the side of my screen. I would really value you to be chatting back, reacting to me in that column, so that I know that I'm not talking into an abyss, but that I'm talking and it's making sense, or you're responding to what I'm saying. So please say hi, let us know you're here, and react along as you go, as well as posing any questions. So I made the mistake of asking my colleagues who are on the call with me as to who's signed up to join us today, and I was delighted / a little intimidated by the fact that there should be 1,000 of you on the call. So very warm welcome to all of you that are out there. So the plan for today, we've got an hour. We are going to be talking to you, I am going to be talking to you about what our potential Care Quality Commission strategy should look like from 2021 onwards. We think our new strategy is going to be called Smarter Regulation for a Safer Future, and I'm going to be focusing in on what we think is going to be one of our 4 main kind of strands, which is around driving and supporting improvement. So that's what we are talking about today. And my colleagues are going to click on to the next slide, so I can just give you an overview of what we're going to cover. So I'm Kate, I'm joined by Gillian and Tansy, who are from the team that are going to be doing some of the writing on this strategy, and then Jen, Steph and Abigail, who will be, there are my engagement colleagues, and they'll be moderating what you say in the column so that they can share with me the feedback that you give as we go through. So that's who you've got on the call from CQC side of things. So if we can move on, please. So the plan for today is we're going to talk about our purpose and vision. Going to share with you a bit about some of our learning from COVID-19. Going to talk to you about how we think we need to change, give you a bit of a timeline, and then we're going to major in on this topic around what should the regulator's role be around driving and supporting improvement. And it's really important to say that this is absolutely not nailed down yet. So this is an active conversation we're having within the organisation, with my inspectors, with you guys out there who are busily delivering services. So you have a serious opportunity today to influence the way you think we should work in this space. So please, as we go through, receive the information, form a view, and then contribute as we go about what you think we should be doing in this space. So that's what we're going to cover. If you want to move us on, Steph. Okay, so if you're on this call, it's probably because you're a provider in health, primary medical services or adult social care, so no doubt you will be very familiar with this. But just to recap, in case you're not, the purpose of the Care Quality Commission is we are the independent regulator of health and social care in England, and we regulate 30,000-ish providers. We ensure that people get safe health and social care, and that is effective and compassionate. We have an ambition going forward to be a world-class regulator. So we want to be the best regulator we can possibly be. And the reason why we want to do that is we think we have a really important role working in partnership with you to ensure that people get the best quality care that they can. So we have ambitions for ourselves to be the best type of regulator we can be, so that we are together all ensuring that people are getting the most high quality care. So that's what we do and what we want to strive to be. Fabulous, and you're starting to comment as well, which is lovely. Great. Okay, that's good. So so why do we need to change? So much of this is pretty obvious, but in order for us to deliver our purpose, we need to be responsive and agile. So as a regulator, we hold ourselves by the same standards we hold providers to. So we know that good and outstanding providers are those who actively seek feedback, who are always looking outside of their own service for best practice, who are quick to say, we didn't get that right, we need to learn from it and do better. So we are the same. We don't always get it right in CQC, and we need to ensure that we constantly strive to do better so we can be the best possible regulator. Health and social care is changing. It was changing at a pretty phenomenal rate, and then COVID happened, and anyone who runs a business anywhere has had to significantly transform, and that's been particularly evident in health and social care. So we've seen, the vast amount of GP practices transferring their business onto online consultations. We've seen huge amounts of innovation happening across all the sectors about supporting people to maintain relationships with people when they're not able to meet in person. So the health and care landscape, the way care is delivered, is changing rapidly, and we need to make sure that we are able to respond and not block and support that innovation and that kind of dynamic way of delivering things. But also we know that the way we regulate currently means that we don't always have a full picture of care. So we regulate individual providers. So we hold you to account as a home care agency or as an acute hospital about the quality of care you're delivering. And I anticipate that will always be the case. We will always want to ensure that the care you're delivering is of high standard. But actually, we are really interested in how providers work together. So we know that people's experience of the quality of their care is influenced quite majorly by two things. One, the ability to access it in a timely way, and two, how joined up that care is. So particularly for people with multiple needs, how their health and social care professionals work together, share information and support them is absolutely critical. So we're really keen, again, when we think about how we want to regulate in the future, how we can move to regulating providers in a way that says, as well as running your bit of the business really well, as well as running your nursing home really well, your GP practice really well, how are you working with the local dentist practice? How are you working with your local hospital to ensure that when people move between those different services, they're as joined up as they need to be? And finally, in order for us to do that, we need to make sure we've got the right tools and capabilities as an organisation as well. So if you want to move us on, Steph. Okay, lots of lovely hello comments. I'm feeling like I'm in friendly company. That's great. Really good to have you here. Okay, so let's talk a bit about COVID and what has been the most exceptionally challenging times that probably any of us have ever experienced in our career, and possibly personally as well. So CQC and COVID. So you'll know that in March, I think it was towards the end of March, we wrote out to all of our providers and said a few things. We said our priority is, like yours, ensuring that people get safe care. And as a result of that, we made the decision to stop routine inspections. So weighing up the risk of our inspectors going out and potentially bringing infections into services, we made the decision that where services were not high risk, we would not be regularly crossing the threshold during COVID. But we committed at the beginning that as and when the risks were there, we would absolutely go out and look at a service in person as and when needed. So we paused routine inspections, and then we busily started thinking, how do we have the best possible view of what people's experiences are of care when we're not out there seeing it in person? So we at Pace developed something that was called our emergency support framework, which is a way of having a kind of structured, supportive monitoring conversation with providers with quite a narrow focus about ensuring that those providers were as ready as they could be about preparing for COVID and surviving the first few months of COVID. But it was also about hearing what those challenges are for providers so that we could help address them. So in adult social care, we spoke to over 20,000 of our providers. There were major themes, as I know you know, in the beginning around getting access to PPE, major issues around testing, significant issues about the multiple bits of guidance that were issued out, and just as someone who's trying to run a very challenged service anyway, coping with this influx of different kind of changing guidance. So the plan was for our inspectors to be there in maybe more of a supportive role than we've ever been, working with people who are running services to say, how are you doing? What are the issues? What can we escalate on your behalf, and what can we help resolve? I think for most providers, it's been a positive experience. I would be really, I mean, it would be not opportunistic of me to not take this time to say, if you've had a emergency support framework conversation, It went live in adult social care first, then it rolled out to primary medical services, and now it's in parts of the hospital landscape. If you've had an emergency support framework conversation with your inspector, or you've had regular contact from your inspector during this time, can you let us know how you found it? And you obviously don't tell me what I want to hear. Tell me how your experience was. Did it work for you? What was your feedback on that? So we learned a lot during COVID, and we are still learning a huge amount about how we can be as effective as possible at gathering together all the intelligence that sits out there. So all the intelligence we have from whistleblowers, all the intelligence we have from safeguarding, the information that sits within clinical commissioning groups and local authorities. How do we scoop all of that information up, along with people giving feedback on their care directly to us, to give us a dashboard of services where we think they're working really well and they should just be getting on with things, and then services where maybe there's a bit of a red flag warning sign to say they're having some challenges, and how do we use that to make sure we are targeting our efforts of support as effectively as we possibly can. So that's what we've been doing, and we've learned a huge amount, and that learning will go into our strategy and how we work going forward. So if you want to move us on, please, Steph. And I'm just going to take a second to have a great, really good. Thank you for your comments in the chat box. That's fab. So what have we learned? So we've learned the critical need to ensure that where information is sat out there, we effectively bring it all together and have the best possible view of what's going on. And that's important for a couple of reasons. It's important because it gives us the best view of what's happening, but also it's really important to avoid asking for the same information more than once from providers. So again, if you're a provider rushed off your feet, the last thing you want is NHS England asking you for information, is your local authority contracts team asking you for information, it's the regulator asking you for information. So it's really important that we do a better job at taking that information and squeezing out of it everything that we possibly can that reduces, wherever possible, the multiple information requests you get as a busy provider trying to focus on the people you're providing support for. We went live last week with a campaign called #BecauseWeAllCare in partnership with Healthwatch England, making a big plea to people out there receiving services, their loved ones, their families and friends, and people who work in health and care, to tell us what's going on out there. So even if we were doing our routine inspections, you will know that routine inspections happen every so often, every 6 months, every 2 years, depending on the kind of quality and what's going on in that service. But it's only of a snapshot. And actually what we want to do is we want to get to a place where we have the best view of what it feels like. There's someone called Clinton Farquharson, who is the chair of Think Local Act Personal. And what Clinton says is, he says, how do you know people are getting quality care at 12 o'clock, on a Sunday evening when no one else is around apart from the people receiving care? And we want to get to a point where we've got the best possible view of what's happening out there, and people who use services and the people who work in it are a great resource to tell us what's happening out there. The other thing we learned, which wasn't new, but it reinforced it for us, is the importance of joint working. So we've definitely found that during COVID, the issues that were there before COVID have just been magnified, but where there's been best practice, that's also really helped places stand themselves in good stead. So about 2 years ago, CQC undertook a series of local system reviews. So we went out to 20 places around the country to look at how older people were supported at the point of a crisis around a hospital admission. And on the back of that, we produced a report called Beyond Barriers. And what that set out was a bit of a blueprint around what good local system working needs to look like. And that had things such as a joint vision, pooled budgets, commissioning that involved people with lived experience, good use of the voluntary sector, etc. So we did that, and then we started a series of conversations a few weeks ago with providers, so you may have had some of these, to find out what has worked well in terms of joint working and what has fallen short. And again, we found very similar set of ingredients. And this week we're going out to 11 places around the country to undertake what we're calling provider collaboration reviews, which is where virtually we are going to be speaking to the Director of Social Services, the Chief Exec of the Acute Trust, the Chief Exec of the Clinical Commissioning Group, provider reps, to say what has worked really well in how health and social care have come together during the crisis and what has fallen short. And the main purpose for this is to look at best practice, but it's very much with one eye on what a potential wave 2 / a really tricky winter looks like. So that's going to be a really important focus for us over the summer, is understanding what really good joint working has looked like, so that everyone can be in the best possible place for what will undoubtedly be a difficult winter, and who knows what a second wave might look like. And finally, our learning, which, you know, it wasn't learning as such, but it just reminding us again the importance of transparency. So the importance of saying, I don't think anyone is sitting here today, and I certainly am not, thinking that everything we did, every decision we made was absolutely the right decision. And we all know hindsight is a wonderful thing, and we've all learned so much about what this disease is in comparison to where we were in the beginning. And it's really important that we, in order to properly learn from this, that we all feel able to say, on reflection, maybe I would have called that differently, or maybe I would have approached that in a different way, or maybe I would have shared that differently. So the theme around transparency, us being transparent as a regulator, inviting you guys to be as transparent as you possibly can as well, so that we can sit alongside each other and try and do some learning from this together, feels really important. So that was some of our learning from COVID. Wow, I'm looking at lots of really positive comments in the box, which is wonderful. Just to reiterate again, you know, tell us what you think. So if we are as equally receptive to something that hasn't worked very well, or maybe you had your ESF call and it worked well, but you think it should be focused on something different or expanded out. But I am pleasantly surprised by the amount of positive comments that I'm scrolling through at the moment. Okay, great. Okay, so let's move on to how we will change. So these again are early thinking about what we're describing as, I don't know, 4 pillars sounds a bit jargonistic, but maybe the four key ingredients about what we think we need to look like to be that kind of outstanding world-class regulator. And I'm going to major on point 4, but let me just walk you through the other points as well. So the first one is around meeting people's needs, and we are really interested in increasingly regulating through the eyes of a person who receives care. So if I am a mum of an adult who's 25 with learning disabilities, I would want my regulator to be able to tell me how health and care works together in Bristol to support a young adult with learning disabilities to move out of his parents' home into supported living and get a job and be supported to have a life and not just a service. So we are really interested in thinking about how we regulate, how we encourage providers to deliver care in a way that makes sense and matters to people. And in that, we are also thinking about not just looking at people's experiences of care when they come into care, but actually that access point. So we've talked before in our annual report, our annual state of care report, we've talked about access issues, and we've talked about waiting lists, and we last year talked about Age UK's 1.5 million people who weren't fully having their care and support needs met. So we've talked about access before, because we know access is a key indicator for people's experiences of quality of care. So we're interested in what role we do have around people's experience of getting access to the right information and advice, the right support, the right ability to access services. And in that, might we play an increasing role in asking people who work in systems what their understanding is of their local population, what their understanding is of inequalities, and what they are doing collectively to address the inequalities issue. I don't know what your thoughts are, but my concern that the inequalities that existed prior to COVID potentially having just grown during this time, and I wonder whether we might, as the regulator, might have a role in our independent voice about talking about inequalities and what that looks like. So that's a bit around meeting people's needs. Smarter regulation is basically about how we move away from a more one-size-fits-all approach to regulation. So broadly at the moment, we will come out and re-inspect you based on your previous ratings broadly. So if you were a good rated service, then we would come back in 2 years or 2.5 years or whatever it might be. And we want to move away from that to having a much more proportionate approach as to how we inspect, but also a wider range of inspection approaches. So we've got some examples of this. So in hospitals, primary medical services and adult social care, we have an approach to a much shorter type of inspection. So it has different names. So in hospitals and PMS, primary medical services, we call them focused inspections. In adult social care, we call them targeted or responsive inspections. So they are a bit more narrow, looking at a couple of the key lines of inquiry. But what we're interested about going forward is actually how do we have a much broader way of regulating? So how do we increase our monitoring function so that we're only crossing the threshold as and when we need to? How do we take what we've learned about how we can regulate remotely and maybe make that part of our core business? So a conversation we've started in the home care world, and it's very early days, but actually we've posed the question, what is the value add of an inspector coming to a home care agency and sitting in the office where maybe there's 2 members of staff? What would it look like instead if the way we regulated home care services was we looked at your policies and procedures remotely, we spoke to staff when they were off site, so maybe encouraging them to speak even more freely. And what if we spent an increasing amount of time having Zoom calls or team calls with people who receive personal care in their own home? And that's just for example, and it's by nowhere means resolved that that's what we're doing. But we want to challenge ourselves to say, we want to make sure that when we're going into someone's home or into the GP surgery or we're sitting in an emergency department, that we are doing the stuff that we absolutely couldn't do remotely, that we are there getting every bit of value out of being there in person. So that's a bit about smarter regulation. The third one is around safe care. So safe care is not new. We've been talking about this for years, but how do we move to a place where people are not unintentionally harmed as a result of the health and care that they receive? And the way that the way this kind of sticks in my mind is in health services, there's something like, please don't quote me, but there's something like 250 million medication errors reported a year. And in adult social care, we don't have the same reporting mechanism. We don't have the same national way of collecting that data. But one of the ways we collect data in adult social care is through our provider information returns. And what I find fascinating is that 50% of our provider information returns, approximately 50%, report no medication errors over the previous year. And that just kind of poses a question for me that says, are we, every time something doesn't go quite the way we want, do we recognise it? Do we have a way of recording it and capturing it? And then how do we systematically learn from it so that we are all raising the bar on safety for people? So that's a little bit about promoting safety and care, and then we're going to move on to driving and supporting improvement. So if we could click on to the next slide when you're ready, please, Steph, that would be fab. Okay. So none of your comments will get missed. So Katie Wade's comments just caught my eye, saying she hasn't had a contact from an inspector. So I just want to reassure you that Jen and the team will be busily capturing everything you've put down. And a comment such as that, Katie, I'd be really keen for, so probably someone from the team will ping you an email after and say, can you just tell us which service you're from, and then I can just make sure I follow up as well with my team to make sure that happens. So, okay, so this is where we are in the timeline. So we are currently in the middle blob, which is we've done some early thinking, and we are taking the kind of 6-month period that we're in to have these early days conversations with you to make sure that the learning we've took from and we continue to take from COVID is informing our thinking about how we need to regulate in the future. it will lead to a formal consultation that will be happening in winter, and then our new strategy will go live in May 21. So that is the time frame that we are working to. So if you want to move on. Okay. All these, there are really interesting comments. So Laura's just put, would the CQC consider introducing social isolation and loneliness measures into their inspection framework? Oh, that's a really interesting comment. Great, yeah, just tell us your ideas as well. Fab. So driving and supporting improvement. So early days thinking. So some of this is what we do already. So if we think about the spectrum of where we are and where we might transform to, kind of nothing's off the table. So if you're sitting there with a really radical idea about what you think your regulator should be doing around improvement, just put it down. So don't be limited by some of the things I'm going to run through now, because this is just our thinking, and you know, why would you just take our brains when we've got 1,000 extra brains on this call? So I think what we do around improvement at the moment is, I think often there's that relationship between the inspector and provider where there is that improvement component to it. So, you know, some providers talk to me about picking up the phone to inspector, kicking ideas around. If you've got a relationship manager, maybe talking, having some early conversations with them about the way you deliver care and thoughts. So there's sometimes that improvement relationship in that kind of one-to-one dynamic. We do a lot around publications, so you might have seen our driving improvement range, where every year or two we shine a spotlight on health and social care providers where they've kind of gone up 2 rating rungs, so from inadequate to good, or from requires improvement to outstanding, to find out how they've achieved it, what were the components of it, and it's often the same things, such as, you know, as I say, outward looking providers, you know, a constant focus on feedback and a willingness to learn, managers with open door policies, etc. So we produce a driving improvement range every so often. And then I think we also drive improvement through our publications, so our focus on specific topics. But what should we be doing more of or stopping? So just running through this, so we talk about priority areas where we think improvement is needed, and if I just give you one example of that, last June we published a report called I think it was called Oral Health in Care Homes, #Smiling Matters, and we did a focused piece of work where we looked at the relationship between dentists and care homes. And we went out on 100 inspections with our dental experts, and we found basics such as people not having the right, you know, having a care plan around how to support them with cleaning their teeth, having access to toothbrushes, toothpaste, all the way through to challenges about not being able to physically access your dentist, training needs around maybe going out and providing oral health examinations for adults with learning disabilities or people with dementia, for example. So we do publications that we shine a spotlight on something that we think is an issue, and then we weave that into how we inspect so that we can measure what sort of impact that had. So that's one example of something we've done in that space. We set a bar for what we think good services look like through things like our driving improvement product. We help providers to help themselves by thinking about our guidance and framework. We've recently published, so innovation is a really interesting one, and I've been here in CQC for a little over a year, and over the year I've heard many times providers saying to me, well, the regulator is the reason why innovation is blocked, or your inspectors come into services when we're trying to do something new and dynamic and are anxious or worried or mark us down or whatnot. So we've been doing our best to bust that myth and say, actually, you know, provided that people are getting safe care and they want to be involved with innovation, people who receive health and care, please get on and do it. And I think COVID has been a fantastic example of what can be achieved. So about a month ago, we published 300 examples of great innovation in health and social care. So that's something we've done in that space. We champion improvement in areas that matter to the public, and we're thinking about our role in research and evidence-based approach to regulation. So some of that's what we do already that we might want to soup up, but this is where I would like your ideas. So if we can scoot on to the next slide, please, Steph. Okay. So, so if you sitting where you are now, if you could just think and comment for me, just some reflections about, do you have access to the tools you need around improvement? So this might vary depending on whether you're big acute trust, down to if you're a shared live service, or if you're running a small home care agency for 20 people. So do you have access to the support you need to improve? Do you think CQC would be a good place to offer, do you think we should be doing more in the improvement support? So is the regulator the right organisation to offer that? What would it look like if there was an improvement arm in CQC? So I was just thinking, but tell me what you think. So if you're a health provider and you go into special measures, there is often a swoop. This is my perception. If you're a health provider, and this is not the case, tell me. But there's often a kind of swooping in of support, this kind of support package that gets wrapped around you. And I wonder whether that's the same if you're in independent health or if you're in adult social care. And I don't think it is. But what do you think? And do you think there should be? What would it look like if it was us? So how would you have a relationship with an inspector, but also that they offered support to you in terms of improvement? So, for example, if you've got an inadequate rating as a provider, what would it look like if an arm of CQC came in to work alongside you, to shadow your registered manager, to be with you on staff development days, to sit in on interview panels? And what if they worked side by side with you, and at the point that you and them thought that you'd got things to where they needed it to be, what if that then could trigger a new inspection, for example? So I know providers talk about their frustrations when they've got an inadequate or requires improvement rating. Often providers are desperate to say, come back out, look at what we've done, we've turned it around, or we've improved on this, come back out and re-inspect, because actually your rating has a big impact on how we're perceived as an organisation, my ability to recruit, etc. So what if there was a relationship between a service that needed support, an improvement component of CQC coming out and properly rolling up their sleeves and working alongside you, and then in collaboration when you thought you've got to the right place, then triggering a re-inspection? I haven't talked this through with my team. This is just something I've been mulling on over the last few days. What might CQC's role be in terms of benchmarking? Do you think we should have a role in different parts of the sector? So if you're sitting there with a fabulous improvement offer from NHS improvement, then maybe this is a bit irrelevant, or you think this isn't the regulator's role. If you don't have that, what do you think? So I'm going to pause for a minute, and probably Jen, Abigail and Steph have been, steam's been coming off of their fingers as they've been trying to digest the 239 comments that we've got in this chat box. But I'm going to pause and just ask them to pull out any comments about our role in regulation. Over to you, Tina.
So just to say that we have captured everybody's comments. So there's a lot of comments coming through on COVID, on testing and PPE. And if you've left your name, we do have your email address, so we'll get back to any of those queries. There's some great comments coming through about the ESF and experiences, Kate, with inspectors and finding those really, really positive and supportive. Yeah. And again, if there's any queries around those, we will follow them up afterwards. Shall I take a couple of questions here?
That would be great.
Yeah. So the first one we got was in our vision, we talk about being a world-class regulator, and some more thinking about how that would be measured. How would we prove that we're a world-class regulator? Yeah,
I like that. Good. That's a really sensible challenge back. Yeah.
How will the new strategy take CQC out of the space into a supportive space with providers? Sorry. That was another question. How will local commissioning be included in your strategy in the future and assessed as part of the process? And that's from a commissioner.
Okay. Oh, it's from a commissioner. Okay, great. Yeah. Okay. Shall I have a go at just a couple of those? So, so just to throw back the first question to you guys, do you have any idea? So how would we measure whether we were being world class? What would be the role of you in giving us feedback, telling us how we're doing? What would be the role for people who access our services and use our information to make informed decisions about where to go to receive care, in terms of telling us how we're doing? But I think that's a fabulous challenge. I will give that some more thought and see whether anyone else has got any bright ideas. The supportive thing is really interesting. So reading some of these comments and what I've heard so far, my impression is that most providers have this might be a bit bold and you might shoot me down. I think most providers talk about having a supportive relationship with their inspector that has increased during COVID. So this notion that we're all in the most unprecedented times and we need to rally together to think about how we address some of these massive challenges you've been facing. I am really so over the last year I've been thinking a bit about what is the role, the kind of dynamic between inspector and provider that's more so forgive me if this isn't your style, but early on in my career I remember learning about transactional analysis, and it stuck, something sticks in your brain. So the notion that you have parent, child and adult, and in an ideal world you want to have adult conversations with people that you interact with rather than parent-child. And I am really keen that no one experiences their interaction with the regulator as being that parent-child, as being that that kind of coming in saying, you haven't done this, you haven't done that, and the provider responding in a kind of defensive way. I really want us to have an adult-to-adult relationship, and I am really keen to think more about how that is what your experience is consistently. Commissioning is just UK HCA, so the UK Home Care Association, Jane and Colin, who run that organisation, whenever they meet with me, they say, you are judging us on quality, but you're not looking at commissioning, and actually the way we are commissioned to deliver services hugely impacts on our ability to deliver high quality care. So that's what I have heard from providers. It's not in we don't have the legal powers to do so, but I think it's interesting if we think about our strategy, which is about regulating from the experience of the person who receives care. I wonder whether there's more we can do in terms of commenting on the impact commissioning has on how health and care is delivered in a place, noting that we don't have the legal powers to do that. But there's 1,000 of you on this call. This gives some really strong content for when we are having these conversations, which we continue to have, to be able to say this isn't just us saying that this plays a really key role in the quality and outcomes people experience. If we are hearing with one loud voice from all of our provider, from all of our providers, that this is something that cannot be ignored and needs a stronger focus, and that really helps with some of the discussions we're having as well. Where do we want to go to next, Jen?
So there's one here. How can the regulator assess culture in relation to hearing the voice of people supported and their advocates?
So I think we've got pretty strong foundations here, but I think we can do a whole lot more. So we have a group of people called experts by experience. We have a contract for people who have family carers of people in receipt of care or who receive care themselves, and wherever possible we have an expert by experience go out with our inspectors to go and see services. We want to do a whole lot more of that, but also that challenge to ourselves about, are we putting sufficient weight and time into hearing directly from people is a question. And then the next question is, where people have additional communication needs, how are we going that step further to ensure that we are really hearing what it feels like? And this is particularly of particular note when we think about adults who are inpatients in mental health wards, often adults with learning disabilities and autism. When we go to inspect those services, and we might be walking into something we call a closed culture, so a service where maybe there isn't that much coming and going of external professionals, where the people are maybe placed a long way from their family homes, so they don't have regular visits from the family, and maybe people with additional communication needs. So maybe they don't have verbal communication, or maybe they use sign language or Makaton, etc. So in those circumstances, we need to do a whole lot more, and we need to work with local advocacy organisations. We need to commit even more to hearing from families. You know, what should be my expectation of my inspectors of being able to communicate directly with people with additional communication needs. Now, you know, it seems unrealistic to think of all the inspectors in CQC being trained in sign language and Makaton and etc. But actually, what more should we be doing so that there aren't those barriers there to hear directly from people with lived experience? So we've done a piece of work particularly around close cultures and the way we need to regulate those services differently. But I think that learning can be expanded out as well, and that's something I and we are really passionate about.
Okay, there's one here that's got quite a few likes there, Kate. Could the CQC help coordinate the mapping of local services? A challenge for providers is often knowing who else is out there and what they offer in order to collaborate. Oh,
I love that. So I think we definitely can in terms of regulated services. So the move we've been trying to think more about how we have a better presence within a place. So whether and when, you know, the whole, how do you define a geography? Is it the STP, ICS, latest health description of how it's organised? I often think about it's how people describe what their home is. So I live in Oxfordshire, so my place would be Oxfordshire. If you live in, you know, the London Borough of, or if you live in Birmingham, so I'm really keen that we, as the regulator, have a really good understanding, have locally based inspectors who know the health and care providers in their patch, who have a pretty good view of risk of what's going on in that place, and who can work to help connect providers up and work with the local commissioners, etc. I think the shortcomings with that approach is that so much fabulous activity sits out there in the voluntary sector, in the community groups, in the self-organising advocacy organisations, and I just wouldn't want us to be too narrow in that. And so I don't know whether we would be best placed. I don't know whether the information we have about regulated providers within a patch could feed into more of a local approach to really knowing what that offer is locally. But happy to have your feedback and reflections on that. That would just be my initial reaction.
There's another one here with a few likes. Could you provide a recommended bank or resources for person-centred care plans? It could be a minimum that we need to have. Then it's up to the individual providers to make them more person-centred to their individual clients.
So this is interesting, and it's interesting in terms of our role around improvement. So should our role in improvement be being a bit more specific? So I know providers often ask us, well, which, you know, I want to move to electronic care planning, which one would you recommend? Or I want to introduce a new way of doing this, which one would you recommend? And we tend to avoid being too specific, because I suppose we are acutely aware of the impact we have as, you know, as the regulator, and the risk is if we say it's that one, then suddenly everyone will think that's the one they need to use. And I get torn between whether our role should be more about outcomes. So, you know, we're interested in people receiving really great bespoke person-centred care. Kind of how you get there is up to you. But I guess if you're a small provider, maybe without a massive resource, you don't have a massive head office, then maybe that would be something that would really add value to you. So I am really happy that we consider that request about could we be more specific, or have a bank, have a suite of information that says this is a good capacity assessment. This is a kind of ingredients of what a good mental capacity assessment looks like. So let me take that away and have a think about that.
So this one's more of a thought, Kate, but it's a good discussion, I think. Commissioning and partners, in brackets GP, hospital discharge, pharmacy, hugely impact our service provision. The regulator needs to approach the provider in the holistic journey. If something is impacting the individual's journey, understanding that care providers will not be able to provide the best care as we are dependent on other partners. So it's about that second look.
I completely agree, and that is absolutely where I would like us to be more. So so I made a comment a week or two ago that says, you know, so I'm just saying this to kind of push our thinking. This may not be the right thing, but you know, what if you couldn't be a good or outstanding provider unless you could demonstrate how you were working in collaboration with? So, you know, if you were, you know, what if you couldn't be a good or outstanding acute trust unless you could demonstrate that your interest absolutely went beyond your hospital walls and your interest was around the prevention and the working with a local GP or the local community nursing team? What if you had to demonstrate your interest was around ensuring a really good care plan handover to the home care agency or the care home or whatnot? So what if that's the way we regulate going forward? Is you've got to deliver absolutely high quality care, but what if there was some sort of a thing that you had to pass, and in order to pass it you had to show how you worked in collaboration with other providers to deliver good joined up care, for example.
So there's been a question here, Kate. How would CQC avoid a conflict of interest and stay objective if they were inspecting improvements managed by their own organisation?
Yeah, so that's a perfect reason why you'd maybe say, well, maybe you would either say don't do it, or you'd say you need to think super carefully about this. So that was the first reaction when I talked about this with some people in my organisation. There is definitely a nervousness about how would that work, and so I don't know, but I wondered whether it could work a few ways. So you keep your bespoke inspectors over here that still have a relationship with their providers, but what if over here you had inspectors who specialised in improvement? What if you know, what if you're a good or outstanding provider, what would it look like if a couple of your staff were seconded into the improvement team? What if you're a family carer or a person with lived experience, you were in that improvement team as well? What if we had, it wasn't just CQC inspectors, there was a suite of, so if I run a business, I've got a fabulous registered manager who's come into my service, really raised the standards, my service is now absolutely rock solid and really delivering. What would it look like if one day a week I seconded my registered manager into the CQC's improvement team, who then goes into another service with the CQC improvement inspector, and was able to say, look, I run a service similar to this. This is some of the ways we've approached this. I don't know, but I think if we wanted to do it, I think if it was the right thing to do, I would be confident that we would be able to work out together how we would draw that distinction between the two. Yeah.
That's great. Are we all right to keep going, Steph, or with just one more question before we move on? Is that okay?
Yeah, we can have one more question.
Yeah, that's fab. So this is more a comment, but it was said earlier, so I don't want to miss it. I like the idea of working alongside CQC to get it right. We could be left to work through the improvement plan, and then some things still may not be right. So if CQC were there, then they can give direct guidance at the point of making the improvement. However, my concern would be that staff and the people we support would feel very on edge should an inspector be around for longer than just the inspection. As well as the need for the manager and the staff to also manage the day-to-day part of the job rather than having the time to spend days with an inspector.
Yeah, so definitely get that, and I know we've got, so it goes back to that, do we have a parent-child relationship, or do we have an adult-to-adult relationship where the inspector, that I don't know, I mean, there will always be that, I absolutely get there will always be that kind of power dynamic there. I wonder whether the difference would be the inspector, it wouldn't be like an inspection. So the inspector wouldn't be saying, can you pull me 5 care plans? Can you show me where X is done? Or, you know, I wonder whether the difference would be, you know, maybe the improvement inspector would like work a shift with your team, or just get themselves immersed in how the care and how the health and care was being delivered. So instead of drawing asks down from you, they would be there a bit rolling up their sleeves, and then whether at the end of the day you'd have a kind of debrief or an opportunity to share reflections. again, I don't know. I definitely don't have the answers. This is very early days thinking, and it may be that we go a bit down this road and then we say, actually, this is not, we're not in the right place. This is not the right thing to do. But I think that would be the difference. Is it wouldn't, hopefully, it shouldn't be calling. It shouldn't be depleting, where maybe I guess sometimes an inspection is, you're trying to run your business and then, oh my God, I've got a CQC inspector sat in my office asking me for load of things. I would envision it more that they would be part of your team for a little while. What if they came and worked in your service for a week and gave you those reflections each day, and you try and do something a bit different the next day. Just seriously early days thoughts, but yeah, that was my reflections on it so far.
Just quickly before we move on, because I don't want to lose it in the thread of 1,000 things. So there's been a few comments about our relationship with Skills for Care and whether we could join up with them on creating some improvement resources and things like that with our new strategy.
Yeah. So I think, so say we did do something in this space. There, no way would I think that we were, the answer. We were the answer to all. I wonder whether it would be more that we would help coordinate bringing in the different expertise. So you've got so in adult social care, forgive me, health colleagues on the call, you have Skills for Care, you've got the workforce resources, you've got the values-based recruitment resources, you've got a lot of knowledge that sits in SKY, the Social Care Institute for Excellence, you've got a lot of fabulous stuff that happens in Think Local Act Personal. So I wonder whether it wouldn't be whether we would hold the kind of ring on this, but you would absolutely bring in different organisations around improvement. But if we were to do that earlier comment about could we have a bank of what good looks like, you would absolutely want to work with subject experts such as Skills for Care to say, a good approach to recruitment looks like values-based approach, takes these sorts of things into consideration. So yeah.
Fab, do you want to move on the presentation, Steph?
Should we move on? I think we're all almost done on the presentation. So okay, so this is so we're just wrapping up. We're just going to talk to you a bit more about how you can get involved. So if we move on to the next slide, Steph, about the different ways you can carry on this conversation. So we have a new tool called our Citizens Lab, and this is where you sign up to it. I think you give your email information, and when it's a way to kind of consult, but on a much bigger, more dynamic fashion than inviting you along to a workshop kind of every 6 months or so. So when we've got something new that we want to talk to you about as the sector, we pose some information. We might put a draft policy on there to ask for feedback and comments. So if you wanted to sign up to our Citizens Lab, that would be great. We regularly publish a provider bulletin, which hopefully draws together all the different bits and bobs that have happened in those previous few weeks that you need to know about. And then we are on Twitter, so we're on Twitter as at CQC Prof, but also I'm on Twitter, so please use that as a way to keep up to date with stuff, but also use it as a kind of interactive way of having conversations with us as well. So if we just skip on, I think, to the final slide. Okay, so before I just pause and say, I'm absolutely delighted with how active this has been as a conversation, and this feels incredibly constructive. So just if you've taken the time to give up an hour and to add your comments, we will be absolutely scrolling through this to make sure we don't miss anything. So so thank you. Is there any final questions, Jen, that we want to ask before we wrap up this session?
So I've got just one here. It's had a few likes. Could CQC orchestrate a support arm via the local authority to improve relationships? Ooh. Then CQC could follow up with guidance and inspection.
Yeah. So yes, I think so. A few things about that is obviously a whole load of our providers just provide support for people who are self-funding and don't have a particular relationship with their local authority unless there's a safeguarding or that sort of issue. So I think I just want to recognise that up front, that would maybe work if a large chunk of your business comes from the local authority, but we just need to be mindful of providers who just provide to self-funders. I think we need to, so obviously local authorities have, well, depending on which local authority you're in, they often have a kind of quality monitoring function. Obviously clinical commissioning groups have their quality surveillance groups and their quality teams. Sometimes there are health teams out there that go into services to provide support. So there is that suite of support out there. I just wonder, I wonder whether it's sufficient, whether it hits the spot, whether it could be more coordinated, and whether there's more that we can do in that space. But I think either way, working with the local authority will be absolutely critical in terms of sharing information and views, etc.
Getting lots of positive feedback about the webinar, so that's great. And just to say as well that a copy of these slides will be circulated to everybody that's on the call today, so you don't have to worry about that. And there'll also be a recording that we'll put up on the external website as well.
Okay, great. Yeah, no, fab. So Simon's just put that, yeah, an inspection is retrospective. How do we move to that more real-time view of what's going on in services? And that is Simon, that is what we want. That's the ambition. So fab. Okay, well, I think this chat stays open even as we wrap up, so so keep commenting on it. You will have the engagement team's details probably through how you book this, so if anything pops into your head after that you wish you said, contribute and sign up to our Citizens Lab so we can keep this discussion going. And just a massive thank you from me. It's been a really I always feel a bit weird because it kind of I suppose your contributions has made it not feel one way, which has been great. So I think unless there's anything else, Jen, Steph or team, I will suggest we wrap up there.
Yeah, that's great. Thanks, Kate.
Okay, brilliant. Massive thank you to you all. And just one final thing before you go, just want to take this opportunity to just say, thank you. I can't imagine how tough the last 14-16 weeks has been for you, and just a massive thank you from me to you. And if you could pass it on to your team, your dedicated staff, the people that say goodbye to their families to go off and deliver health and care to people. So just a massive thank you from me for everything that you all do every day. It is completely appreciated, and hopefully one of the legacies of COVID is maybe some parts of our sector will finally start getting the recognition it deserves for the work that happens. So thank you, and we will finish there.